I'll be dealing with the management aspect of inflammatory bowel disease. This is going to be just an overview. Patients of ulcerative colitis basically present in two ways to our clinic. So most of our patients, say 90 to 95% of our patients, usually have a very chronic, relapsing and remitting type of symptoms, and the patient will have suffered symptoms for a very long time before they come to our OPD. The other type, around 5 to 10% of our patients can present with fulminant colitis or toxic megacolon as a first presentation of their disease, ulcerative colitis. This is thankfully rare because it's an emergency situation. Most patients, as I already told, present in a chronic relapsing remitting fashion. The patients usually have diarrhea, and that there is presence of blood and mucus in the stools. The frequency of diarrhea as well as the presence of blood basically depends upon the disease activity. More severe the disease is, higher will be the frequency of the diarrhea, as well as higher will be the amount of blood the patient will be having in the stools. A small percentage of patients can present as fulminant colitis or toxic megacolon, as I told, as a first clinical manifestation. Rarely it can occur in patients with known case of ulcerative colitis. On acute exacerbation can go very, very fulminant and very can develop toxic megacolon. A known case who has had a chronic relapsing remitting type of clinical presentation can one day suddenly develop very severe fulminant colitis, so it can present to us with severe fulminant colitis. They have severe pain abdomen, distension of abdomen, bloody diarrhea going 12 to 15 times a day, and can have severe dehydration exaggerated, which have all the features of systemic inflammatory response syndrome. This is an emergency situation, has to be dealt with accordingly in an emergent manner. So the most important investigation for us to clinch the diagnosis as a clinician is basically a colonoscopy, to visualize the mucosa of the colon as well as to take biopsy from it so that we can confirm the diagnosis. So colonoscopy and biopsy is the most important investigation that these patients have to undergo. And the purpose basically, as I told, is for clinching the diagnosis and basically to assess the extent to which the colon is involved, the severity of the disease, extent of the disease, to know. In a known case of ulcerative colitis, who we already know is diagnosed case of ulcerative colitis, and he's on treatment on. In such patients, again, the importance of colonoscopy is for surveillance for malignancy. So we do know that the patients of ulcerative colitis is a pre-malignant condition. These patients can develop malignancy depending upon the duration as well as the severity as well as the extent of the colonic involvement. So every 5 yearly, surveillance colonoscopy is advised for these patients, and every 5 centimeters, 4-quadrant biopsy has to be taken randomly in these patients every 5 yearly. And if there is any specific area where there is a presence of any mass lesion or presence of any stricture, so such areas should be concentrated while doing this colonoscopy. Biopsies have to be specifically taken from such areas. And the other routine investigation basically for assessing the severity of the disease in a patient of ulcerative colitis is basically total counts, gives us the idea of presence of inflammation as well as C-reactive protein, CRP levels indicate the activity of the disease. So whenever there is an acute exacerbation, and to assess the response to therapy as well, C-reactive protein is very much essential. So whenever the patient gets an acute exacerbation, 2 important things that we should rule out is presence of a cytomegalovirus infection and presence of a Clostridium difficile infection. So it can be done by stool examination or by culture of the stools. So basically, we need to these 2 infections, Clostridium difficile infection and cytomegalovirus infection, can cause an exacerbation in the case of ulcerative colitis. Their studies have to be ruled out. And to know the disease activity, to test specifically done on the stools are basically stool calprotectin levels and stool lactoferrin levels. They give us the idea about the disease activity that's going on in the colon. And then there is contrast enhanced CT scan in patients, especially those patients with fulminant colitis, toxic megacolon, and where you're suspecting there is a perforation, where suspecting there is a malignancy. To stage the disease, we may require a contrast enhanced CT scan to be done in these patients. Now, to assess the severity of the disease, it's very important because we tailor our treatment to these patients basically depending upon the severity of the disease. So, True Love and Wits criteria has 6 parameters, clinical as well as laboratory parameters, which give us an idea about the severity of the disease. Basically, number of loose stools per day, presence of blood, temperature, if the patient is having fever or not, if there is a tachycardia, if there is anemia, and ESR basically gives us an idea regarding the underlying inflammation. This can be replaced by CRP as well. So depending upon these clinical parameters, we classify this patient's severity of the disease can be assessed. Coming to the treatment aspect, most patients basically would be asking us regarding the diet that needs to be followed. The patients of ulcerative colitis or Crohn's disease, they usually tend to ask what diet is better. So, general guideline is that anything with rich in antioxidants, anything rich in omega-3 fatty acids are good. Other than that, red meat, high fat diet should basically be anything. High fibers diet should basically be avoided in these patients. This is basically a list of drugs that are used in the treatment of patients of ulcerative colitis. These are the same drugs that we use for Crohn's disease as well. Most importantly, we should understand that there are some drugs that basically are used for induction of remission, and there are a few drugs that are used specifically for maintenance of remission. 5-meno-salicylic acid, mesalamine, mainly used to induce remission as well as maintain remission in mild to moderate cases. Steroids, either in the form of budesonide, prednisolone, or IV corticosteroids in the form of methylprednisolone or hydrocortisone, would basically be used for inducing remission. And once we start, steroids should basically be used for beyond 8 weeks. So they cannot be used for maintenance of remission. They should only be used for inducing remission, mainly for moderate to severe cases. And then there is this class of drugs, the immunosuppressants, cyclosporins and tacrolimus. They are basically used for inducing remission, and they shouldn't be used. They are usually not used for maintenance of remissions and used only for severe cases wherein the corticosteroids have failed. There is this group of group of drugs which we call as biologicals. These are basically monoclonal antibodies directed against specific agents, basically anti-TNF alpha, anti-TNF alpha, or anti-integrins. Vedolizumab is basically an anti-integrin antibody, and anti-TNF alpha antibodies are infliximab, adalimumab. These basically are used for very severe, moderate or severe cases, for both for induction of remission as well as for maintenance of remission. Now, the importance of assessing the severity of ulcerative colitis is basically to tailor the disease, tailor the therapy for the specific for the disease. So mild to moderate cases, we can manage. The induction can be induced by using 5-aminosalicylates, and the patient can be maintained on 5-aminosalicylate therapy. Moderate to severe cases would require corticosteroids to induce remission, and then maintenance therapy can be maintained on 5-aminosalicylates with or without thiopurines. And very severe cases would require either IV corticosteroids or immunosuppressants like cyclosporin or biologicals to induce remission. And once remission is induced, can be maintained on either biologicals or thiopurine. and specific conditions where surgery would be required. Indication for surgery could be either an emergency situation or an elective situation. Emergency situation, if the patient is having a severe bleeding, if there's perforation, toxic megacolon, pulmonary disease which is not responding to our regular management with IV corticosteroids or cyclosporins or biologicals, such patients would basically require an emergency surgery. And in elective setting, basically, if the patient is not responding to medical therapy, medical management, or if the patient is not able to tolerate the side effects of the medical management, or if there is any suspicion of malignancy or presence of malignancy, and specifically in pediatric patients, if there is growth retardation or failure to thrive, the patients would basically be taken up for surgery. What surgery we do? Basically, we remove whole of the large bowel, starting from the IC junction to the ileocecal junction to the rectum. So whole of the large bowel is removed. And after that reconstruction, either we can create a pouch of the small bowel and anastomose back to the rectum, which is called as total proctocolectomy with ideal pouch in anastomosis. And in elderly patients and patients who have anal sphincter function is not that great, so we can go for total colectomy, and a permanent ileostomy can be done for these patients. Coming to Crohn's disease, again, there are three phenotypic varieties of Crohn's disease depending upon the phenotype of the disease. Basically, it can be inflammatory variety, an obstructing variety, or a fistulizing variety, and it can progress from one to other. It can progress from inflammatory to an obstructive variety or into a fistulizing variety. And the clinical presentation basically depends on what phenotypic variety or what changes basically are occurring in the involved segment of the bowel. So as already mentioned probably in previous modules, Crohn's disease can evolve anywhere from mouth to anus, and specifically more commonly involves the small bowel more than compared to that of the large bowel. And it involves multiple segments with skip areas in between. So the patient symptoms basically depends on whether there is just inflammation or there is an obstructive type of stricturing type of disease, or if there is a fistulating type of a disease. And these would be the clinical presentation the patient will have. Most commonly will be patient can have pain, abdomen cramps, can have constipation, rarely diarrheas. If specifically there is a fistulizing disease, can have perforation, can have intra-abdominal abscess formation. And the characteristic feature of Crohn's disease when compared to the ulcerative colitis is that there is a relative rectal sparing and involvement of the perianal region in Crohn's disease. The rectum is spared, but the perianal region is involved, and perianal region is involved especially in up to 20 to 25 to 30% of our patients. And it can be either in the form of an abscess, perianal abscess, or a perianal fistula, or a fissure. Investigations basically depending upon what the patient presents to us with. Most important would be basically be contrast enhanced CT scan or a CT enteroclysis. CT enteroclysis, we make the patient drink negative contrast. Most commonly is going to be just water, and a contrast enhanced CT is done, which basically shows us any sites of inflammation in the small bowel, or there is a presence of any segment of strictures, or presence of any fistula should basically be made out, and presence of any intra-abdominal abscesses can basically be made out with this investigation. So most important would basically, I would say, as a CT enteroclysis or contrast enhanced CT scan. Though we need tissue diagnosis before we start our treatment, which we would be able to get by doing an upper GI endoscopy or a lower GI endoscopy and taking multiple biopsies from suspicious areas of intestines. So as I already told, small bowel is the most commonly involved segment, is most commonly involved part of bowel in the Crohn's disease. And enteroscopy involving the small bowel can be done by doing something called as double balloon enteroscopy. So we can visualize as well as take biopsy from the area of interest while doing an enteroscopy. And then there is this capsule enteroscopy as well, where there is a small capsule of around 1.5 centimeters of size, and that has got a camera which at its tip, which clicks pictures and sends it to a processor, which is kept by the side of the patient. So it clicks pictures, and we later collect those pictures and analyze those pictures, and can get visual impression of what's happening in the small bowel. But again, capsule enteroscopy, we can't do any interventional procedures. We can't take a biopsy from any area of interest, and if a patient is having an obstruction, it can't be done. The capsule can actually go and get obstructed in the small bowel and can actually exacerbate the obstruction. The medical management, basically Crohn's disease is a disease that has to be treated by maximally in a medical manner, in the sense non-surgical treatment. So it's basically the same drugs, only that 5-methylsalicylic acid would basically be less effective when compared to that of ulcerative colitis, and more role for steroids in inducing remission when compared to that of ulcerative colitis. Of course, steroids would be more commonly used when compared to that of ulcerative colitis. And again, steroids, once started, should be stopped within 6 weeks, only to induce remission, not to maintain remission. And there is a higher role for immunomodulators, the azathioprine, and of course, biologicals are more commonly used in Crohn's disease than ulcerative colitis. As I already told, it has to be treated maximally by drugs or medically rather than surgically, because as I already told, it can involve multiple segments of small bowel at multiple levels. So you can't just treat one, you can't just remove the small bowel and more. And once you open the abdomen, more adhesions will be formed. Adhesions can exacerbate the symptoms, can cause more obstruction, and the wounds won't heal properly in these patients of Crohn's disease. So we try to manage these patients of Crohn's disease medically rather than surgically. And the treatment has to be tailored depending upon the severity of the disease, and it can be tapered down depending upon the response to the therapy. So surgically, as I told, that's going to be a last resort in case of Crohn's disease. Emergency, if a patient is having perforation, the patient is having bleeding, then we are left with no other choice, have to operate. Especially in Crohn's disease, it will be obstruction rather than perforation or bleeding. Fistulizing disease, there can be small fistula or small perforation in the small bowel that can cause local abscess. If it is contained by bowel or by omentum, can form a local abscess. So we try to manage as much as possible by minimal invasive methods, by ultrasound guided or a CT guided aspiration or insertion of a pigtail or Malakoff's catheter to drain these abscesses out, and try to avoid surgery as much as possible. In elective setting, of course, perineal disease, there is an abscess, we try to drain it surgically. Presence of any fistulas, we try to use statins, insertion of statins for treating them. Of course, if there is presence of malignancy, then we are left with no other option than to do surgery. The problem of doing a surgery in Crohn's disease, as already mentioned, will form more and more adhesions, and then there is no end to it. It can involve multiple segments, multiple sites can be involved. So we may have to do a resection and anastomosis of small bowel, and if we do resect a very long segment, the patient can have a short bowel syndrome, wherein the amount of the length of the small bowel is not adequate enough to maintain the nutrition of the patient. So we try to avoid doing maximal large segment resections and try to keep the resection to minimal, do resection anastomosis, and try to use the bowel as much as possible. Whenever there is a stricture, we do either a side-to-side anastomosis or a stricturoplasty, and try to avoid surgery as much as possible. That should be this is my last slide. That should be the end of the presentation. Thank you.